morning, everybody. Welcome to our webinar on norovirus prevention and management, in which we are putting on here at Qualis Health. Qualis Health, for those of you who are not as familiar with us, is a quality improvement organization for Washington State and Idaho, in which we are contracted with the Centers for Medicare and Medicaid Studies to provide free technical assistance to nursing homes, critical access hospitals, and other healthcare settings that accept Medicare payments. Every quarter, Qualis Health holds a webinar that features a topic of interest across healthcare settings, such as readmissions, or in this case, norovirus. And we open those webinars to all providers of the target settings in order to help spread the learning and to disseminate information and knowledge, and for providers to be able to share some best practices and other things that they have learned, since you guys are the experts in providing care and services. Since we are in Noro season, we thought that this would be of interest to you, and we're excited to say that we were right, because as of this morning, we had 100 who registered for this event. So we're very excited to see so many of you joining us. So, okay, whoops, hit the wrong key, Amy. So for today, we will not only be reviewing best practices for outbreak prevention and management, you're also going to have the opportunity to hear from your peers who are going to share what they learned from their experiences with a norovirus outbreak. And then we'll together have an opportunity to not only talk about some questions, but also explore some areas for improvement. I'm going to flip back here to the housekeeping piece. Just so you know, I am in the room with Jamie Moran, who is our featured speaker, as well as Paula Parsons. So don't be confused when you look up on the top left, on the top right part where it says who is speaking. It may say it's Paula Parsons, but it may be any of us, and we'll be sure to announce who we are before we start speaking to minimize any confusion. Again, we're going to be monitoring the chat box for questions throughout, and you're welcome to ask a question throughout this presentation, not just in the live Q&A sessions. But please be sure, again, to, when you type in your question, that you go down and click in the box above it and send to all participants. Otherwise, we aren't able to see it and won't be able to answer it. So on that note, I'm happy to introduce our first speaker. We're going to start with talking about a couple providers from a critical access hospital and a nursing home in Idaho who are going to be sharing their experiences with a norovirus outbreak in order to set the stage for this important topic. So I am going to open up with Laura Showers. So Laura, please share your story at this point. You can go ahead and unmute yourself and begin. Okay, let's see. Laura?
There we go. Hello.
Okay. Hi.
Hi there. Can you hear me now?
Yes.
So this is Laura Showers. I'm from Port Townsend, Washington, Jefferson Healthcare. We're a critical access hospital here on the Olympic Peninsula. And last November, a year ago November, I got a voice message one morning when I came into work from one of our night shift house supervisors, and there had been 5 patients from local assisted living coming to our emergency department, and they all had vomiting and diarrhea. And they admitted one of those patients to our acute med-surg unit, and so I thought, oh, okay, this is something. I've been at that point I'd been in this job for about a year and a half, and we hadn't had an outbreak but I did have a policy that I had written, so I luckily went and referred to my policy anyway and started tracking things. So we immediately had a nurse get sick and was admitted to the nurse from the ICU who had taken care of this patient went to our emergency department because this person was so sick that they needed rehydration. So over the next couple of days, we had multiple patients admitted to the hospital from the assisted living, and we just had one staff after another getting sick. We did have one patient who had been in for a joint replacement, a total knee, and had been in our swing bed department, and that person also became ill and had been healthy. So my assumption, and in my review of the staff taking care of that patient, one of the staff who had gotten sick had been taking care of that patient, so it seemed possible that the patient had gotten it from that staff member. So over time, nursing staff became ill, and then then it stopped. It lasted for about 5 days, the outbreak. And so if you go to the next slide.
Okay, and so that's the one that's titled Investigations and Actions?
Yeah, okay. Yeah. So what I did during the time was, so when I realized pretty quickly that it was an outbreak and assumed it was norovirus, I contacted the health department and worked with them, and they already had been contacted by this assisted living facility. And so I talked to so I was in contact with the health department, and the assisted living was as well. And the health department had given recommendations to the assisted living, and they shut down their cafeteria, and they kept their residents. They had them stay in their rooms. They reduced cohorting of their residents. And then at the hospital here, I alerted our house supervisor staff, our hospitalists. I also notified our clinics, and of course our clinical staff. And I sent out a bulletin. I put up flyers, and I also did a lot of rounding and let people know that we had this outbreak. And we also, I got some information from the health department and posted signs about how easy it is to get noro, how easily it's transmitted, what the symptoms are, and then also heightened the alerts for patients coming in with vomiting and diarrhea so that we got them in enteric transmission-based precautions quickly when they came into the hospital. And I think that's pretty much. Also, during this time, I also tracked everything. I kept a journal. I kept a line listing of all the staff. I worked with the employee health nurse, and she also kept a line listing. We encouraged staff to contact her. They didn't need to give any names, but to contact her and let her know if they were sick with a diarrhea or vomiting illness. And so a number of people did, and that was part of the way that I got the information about staff illness. And then the next slide. So I used the policy that I have written. I used CDC resources for. They had they have an HAI outbreak investigation toolkit, and there's a good article that I had read about perspective on outbreak investigations, and I also have a reference that I got from EQuIP that has some policies, and so I had used that to write my policy, and I was able to follow the policy and do the tracking, and then determining the characteristics of the case and coming up with a tentative hypothesis and working with the health department. We never tested anyone for noro, but we did, most of the patients in the hospital were tested for C. diff and CAMPI, and those were all ruled out. So we presumptively assumed it was norovirus, also considering how quickly it spread. And so we didn't test the hypothesis because then the outbreak just stopped almost as quickly as it started. So I think that's all I have for this.
Thank you very much, Laura. Thank you for sharing your story. Now I'm going to turn it over to Lori Bensler, who represents Twin Falls, Idaho. And Lori, please unmute yourself and tell us a little bit about yourself and your nursing home's experience with noro.
Health Center. Our outbreak actually occurred almost 3 years ago today, and it lasted a little bit longer than the instance the first speaker talked about. We had one resident on December 15th, 2012, that showed some symptoms, had some vomiting and diarrhea. And that was the first instance of anyone showing any symptoms. Then we didn't have anything for a couple of days. On December 17th, we had a couple of staff members who started having symptoms. On the 18th, we had another resident on a different hall who started with vomiting and diarrhea. And then by the 19th, we knew we had an outbreak. We had 5 new residents who started showing symptoms. And at that point, we put a lot of measures in place as far as isolating residents. We stopped having group activities. Only the residents who did not have any symptoms could go to the dining room for meals. We didn't shut down the whole dining room, but the same thing for our therapy. Then as time went on the 20th, we had 12 new residents. By the time we were done, we had 34 total residents who had some type of symptoms, either nausea or vomiting or diarrhea, and we had 31 total staff. So the first symptoms started on December 15th. The final cases were on Christmas Eve, December 24th. So it lasted about 9 days. We did not have any new symptoms develop after that. We had limited therapy. Excuse me. Once residents stopped having any symptoms, they still had to stay in their rooms for 48 hours. Only one of the residents was hospitalized and none of the staff. So all of them recovered fairly quickly. We did do labs for rotavirus, for Salmonella, E. coli, and C. diff, and we also did check for norovirus. There were no positive results from the labs that we did, but because it spread so quickly, that was our assumption, that it was norovirus. We had started doing, after the first resident showed symptoms, we did a lot of education with the staff with hand washing, making sure they were following isolation procedures. Our only challenge with this whole process was it was right before the holidays, so we had a lot of families coming to visit. We did stop visitors from coming in for a couple of days just because of the significant numbers of residents that we had. And we also had a challenge in getting enough masks and gloves. So we were scrambling to get supplies. But once it stopped on Christmas Day, we had no new symptoms, and everyone recovered.
Okay. Thank you, Lori. Do you have anything else that you'd like to share with your experience that you think would be valuable for other nursing home providers and critical access hospital providers that could benefit them as they prepare for norovirus season?
I think our biggest challenge was the timing. Because it was the holiday season, we had to cancel a lot of programs that were coming in, and that meant, the whole community knew what was going on. We had talked to the health department, so it took a little bit after Christmas for visitors to start coming back. But it was a challenging experience because of staffing, having that many staff sick. We had a lot of managers who worked extra and helping out. It's hard when you have that many staff members who also get sick.
Absolutely. Thank you so much, Lori, for sharing your story. We really appreciate it.
You're welcome.
All right. Okay, and so right now we're going to break this up a little bit, and we're going to have our featured speaker, Jamie Moran, who is going to talk for us for about 15 to 20 minutes about some best practices review. And so Jamie is a certified infection preventionist. Yes, to be a professional in infection control these days, you do need to have certification. And she's been working at Qualis Health for about a year and a half. And she works primarily with hospitals, but she's also been working with us in nursing homes as we're preparing to work with nursing homes to improve their infection prevention systems. And so I'd like to remind you that if you still have a question, you're welcome to enter them at any time. Just be sure that when you enter it in that you send to all participants, otherwise we don't get to see it. So on that note, I'm going to turn the floor over to Jamie. Thank you, Jamie.
Thank you, Amy. Well, hopefully everyone on the phone today is norovirus free, at least for the day. We do know that we've had several large outbreaks of norovirus already here in the Seattle area, making the news. And if you follow the national news, Boston College and some other places have already experienced it. So it may be a tough year with regard to norovirus. All right, let me change the slide here. So let's talk a little bit about what norovirus actually is. This is a picture. This is a very, very bad virus. It's not particularly dangerous, but you will feel terrible. This is just, nobody wants this. It is a non-enveloped, single-stranded RNA virus, and it's part of the Cheliciviridae family of viruses. Norovirus is just one of several that's in that family. And even within the norovirus strain of this virus type, there's at least 25 different versions of it, and then some subspecies along with it as well. So you may also, it's also all of the viruses in this family will cause viral gastroenteritis. It is the #1 cause of viral gastroenteritis in the United States. Oftentimes you'll hear it called the stomach flu. Now that's not a correct description. It has absolutely nothing to do with influenza, but generally people will call it the stomach flu, and that should give you some warning bells if you hear somebody call in with that. Burden of disease in the United States, 20 million cases every year of norovirus is what we suspect is happening with it. 1 in 14 Americans every year will come down with this viral gastroenteritis. It accounts for 91,000 hospital visits each year, or visits to the emergency department with 71,000 hospitalizations. And then some studies show 800 deaths associated from norovirus. So it is highly disruptive. It's, again, something you want to avoid at all costs if you can. So the key, in my opinion, to controlling this is recognizing it very, very early. Anything you can do to be on the lookout for norovirus ahead of it will allow you to act quickly and get it under control. So let me tell you a little bit about how you would recognize it. Generally, it will occur year-round, but we see it most often in the winter months. So between November and April is when we see most of our infections, and we think that's because in the winter months and with the holidays, we get people in close quarters, and they share their space, they share their germs with each other, and so we get more outbreaks in the winter months. Now the symptoms, the classic symptoms are a sudden onset of stomach cramps and diarrhea, and about 75% of the people with norovirus report vomiting. So those are the classic symptoms of norovirus. It takes about 24 to 48 hours after exposure to symptom onset. That is if you even know when the exposure was. But it's pretty fast acting too. The other thing that you want to keep in mind is that only less than 20% of people with norovirus will report a fever. So sometimes that can be a differentiating symptom for norovirus. The incubation period we think is between 24 to 48 hours. Some literature will say 12 to 48 hours. And because it's so quickly, it runs through the system so fast, recovery is usually within 72 hours. Thank goodness. Interesting to note that about 30% of people with norovirus are totally asymptomatic. So if you're a lucky person that you don't get norovirus, congratulations. We're all jealous. So let's talk a little bit about transmission. The reason this is such a bad boy is that it doesn't take a whole lot of viral particles to get ill from norovirus. So the literature from CDC does indicate that only 10 to 100 of the virions are needed to cause disease. So it's very contagious. The transmission route, we generally think of it as being a fecal-oral route. Also, when someone has norovirus, they tend to contaminate their environment, and we can pick that up off of surfaces. So we do know it also has a contact transmission route. New evidence, we've suspected it for a while, but some of the studies are now confirming that norovirus during those forceful vomiting episodes, the expression of liquid stool, for example, flushing the toilet is another route. We're learning that it aerosolizes. So it's a little bit, we don't call it, you'll hear it in the media called airborne. It is not an airborne transmission because that means something very specific, but it does aerosolize. And when you are in a room with someone who is actively vomiting, you can get the particles into your mouth, and that is one way to contract the disease. Not that that's a pleasant thought this morning, but it is something to be aware of. So one of the things you might think about is if you can, and this is important at home, close the lid on the toilet before you flush. This is one important thing. The other thing is just advice. If someone in your family comes down with norovirus, try not to keep your toothbrush and your medicine cup and all that in the bathroom where it can become contaminated. So just a little hint and tip for you there. Now, I always get this question, how long does norovirus live on surfaces? Well, it's a persistent little bug. We know from the studies that it lasts at least 72 hours, but in some studies it's still detectable after 5 months. Now, we don't know that it's infective after that long, but it's still there. So this is an important piece of information. So we want to make sure that if we can avoid norovirus, that is the most important part of this whole talk, I think. So what I always try to tell people is expect it, know that it's coming, and prepare for it now before it hits your facilities. So there's a couple of things I want you to think about. Be on the lookout. So if you are not currently monitoring your staff, your employees and your residents and those people that you have regular contact with for norovirus, now might be a good time to contact them. For example, if you have staff members who are ill, even on their day off, you might want to let them know that you would be interested in knowing if they have stomach flu or gastroenteritis type symptoms, just so you can be on the lookout for it hitting your community. This also runs really rapidly through schools and other churches, other community settings. So monitor your community to see if norovirus has hit it yet, and that'll be a good clue for you. The other thing is before it hits, before you have your first case, make sure your staff know what your policies are and make sure that they, run them through those tests. Make sure your communication lines are open so that they get the word very quickly so that you can begin to take action at the very first sign of norovirus in your facility. You want to make sure you have plenty of supplies on hand before you get norovirus. And then the other thing is norovirus can live even in a heated environment up to what we know is about 140 degrees. So you want to make sure that your dishwashers, laundry services, when it's run through the hot water system, that those do get hot enough to kill norovirus. So again, be ready to act. You want to make sure you want to be very suspicious that it's in the area. You want to make sure your frontline staff are suspicious too. So it's okay to share paranoia at this point. Make sure that they're looking at these symptoms, so train them on the symptoms, and then make sure that they're reporting them as soon as possible, not only in their own families, but if they're seeing in patients or residents as well. At the first sign, you want to put these patients or residents immediately into contact precautions. Try to get them into a private room, and everyone that goes in and out of that room needs to have personal protective equipment. That includes gowns and gloves, and something that I highly recommend is a mask, because now we know from the studies that have been done in the last few months, the aerosolization, the mask will help prevent some of that spread, we believe. So add masks to your personal protective equipment. Hand hygiene with soap and water. You can't wash your hands often enough when you're in the middle of a norovirus outbreak. We also are going to recommend that you clean with bleach whenever you can during the outbreak only, or some other EPA-registered disinfectant with a label claim against norovirus. Again, that's a proxy, but it will be approved for that. Also, if you can use disposable equipment, this is a good time to break that out and make sure you have plenty on hand of any kind of disposable thermometers, blood pressure cuffs, anything that you normally share patient to patient or resident to resident. Try to get a disposable equivalent. You also want to make sure that patients and residents and staff, if needs be, are isolated for at least 48 hours after the resolution of symptoms. So even though they're no longer vomiting or have diarrhea, we know that there can still be viral shedding and stool beyond that. So for at least 48 hours, that means they're probably going to be isolated for about 5 days. The question always comes up is how do we know we're in an outbreak, even in the absence of diagnostic tests? So the CDC says two or more cases that are epidemiologically linked. Well, it takes a while to epidemiologically link the cases, and this is such a fast-acting disease that that may take a while. So two or more, consider yourself in an outbreak and start taking action then. But the other thing in the absence of diagnostic tests that you can use is the Kaplan criteria. I mean, if you have more than two cases, if more than half of the people affected are vomiting, and it looks like it's coming on within 24 to 48 hours, and the illness itself lasts between 12 and 60 hours, and none of the other tests that you've performed come back positive, then you are very likely in an outbreak setting. And at that point, you want to put into place your outbreak policy.
Jeannie, we had a question that came in. It was forwarded from a panelist. They have a question about resident quarantine precautions. In this person's experience, when they had an outbreak, some of the residents were independent, and probably more than a few of you have had this experience. They refused to stay in the room, especially if they were smokers. They'd want to enter and exit the facility frequently throughout the day. So they'd like to know if you have any suggestions for what they can do to help with that.
Well, I think that we're going to have a story from Jean Trepanier in just a few minutes, where she had a very similar example, so I won't spoil her punchline on that one. But, you know, these folks are generally really sick, and I know that even after they get better and they have to stay in quarantine for another 48 hours, if you can get them to wear their mask, wash their hands, and mainly education about that they're still shedding virus, and hopefully appeal to their sense of not wanting to spread it to others, that would be helpful. I don't know if that's answering the question, but certainly when they're out in with others, if you can protect them through barrier precautions, gowns, gloves if you need to, hand washing, that may help as well. And I won't spoil Jean's story, but there's I think she's going to be able to address some of this as well. So let's talk a little bit about diagnosis and treatment. I highly recommend that as soon as you suspect that you have norovirus in your facility, go ahead and contact your public health department. The public health department is your partner here. They can tell you whether or not they're seeing other cases, because oftentimes if it's in the community, they're the first ones to know about it. So contact public health, and they're also going to recommend or not recommend testing protocols. So it may be that they know it's in the community, it's already been confirmed, and they won't need any tests. Or they may say, nope, we haven't heard of it, and we'd be really appreciative if you could get a stool sample. And again, you don't necessarily need a diagnostic test to confirm an outbreak. If it meets the Kaplan criteria, consider yourself an outbreak. There is no specific treatment for this disease. What we do is supportive care, rehydrate if needed, possibly antiemetics, and then mostly just making sure folks get through it with as little pain as possible, and that we control it. If you do need to submit a stool specimen, you want to do it as early as possible during the outbreak. So the earlier cases are better so that you can confirm it before others get ill. You can use vomitus, but it has less sensitivity, so we really prefer a stool specimen. And you want to collect that from a person during the acute phase of the illness. So really, within the first 2 or 3 days, that's when you want it. You want to collect the specimen. After that, the viral load is a little bit smaller, and we don't get the yield that we need to confirm. And again, you do not necessarily need to swab your environment. If you're in an outbreak, an extended outbreak, the public health department will make that recommendation, but you do not need to do that on your own. So let's talk about what happens with when you know you have an outbreak. And what I'd like to recommend is that you think about just like any other minor emergency that happens to your facility. Bring everybody together and get a communication protocol in place. Many of the leaders in the facility need to be involved in any kind of decision making, particularly if you need to close the wards. You want your infection preventionist there because this is the person that will be the liaison to public health. Employee health will help monitor your staff members. You want your ward leaders to be aware of what's happening in your facility with norovirus so they can be looking for new cases. They can staff appropriately. They can make sure that all the pieces are in place at the front line that you need in order to contain this. You also want to notify your laboratory, your housekeeping facilities, central supply. All of these people need to know that it's coming, and they need to assess their capacity to handle an increased load. So, for example, if the laboratory is going to be asked to process stool specimens and other things from the health department, you need to make sure that they have all that on hand and that they have the right trained people to do that. Housekeeping, you want to make sure your housekeepers are well trained in protecting themselves from norovirus and how to clean a room appropriately. Make sure you have plenty of sheets, towels, linens. Oftentimes during a norovirus outbreak, we run through those so quickly that we don't have enough on hand. So early in the outbreak, or even right now before you have an outbreak, you might want to go assess to make sure that you are prepared to move quickly in the event this happens. Now, one of the things the CDC recommends, and this is easier said than done, but they consider cohorting your staff and your residents by these three categories. So you have folks that are sick and symptomatic, you have folks that are exposed but not yet sick, and then you have those that haven't been exposed and hopefully will not get sick. And the idea here is that you assign staff to one of these cohorts and try really hard not to go back and forth between the three groups so that you're limiting the spread. Again, easier said than done. In the event you have staff that become ill at work, send them home immediately. If they wake up ill or came in on the weekend, please ask them to stay home. You also want to make sure that they stay home for 48 hours after the symptoms resolve. What we see often, because people are short-staffed during these outbreaks, is they bring people back to work while they're still shedding the virus. So they feel well, but they're still contaminating their environment to some degree. And so CDC really recommends stay home for 48 hours after illness. Also, when you have a staff member who becomes ill, it's really important that you do a contact investigation. What patients and residents have they been taken care of in the 24 hours prior to symptom onset? And watch those folks closely for signs and symptoms of infection. When your staff member returns, I mean, this should be obvious. They should be washing their hands anyway, but this is a really good time to say more often, again, because of that viral shedding. Visitor policy. If you don't have a visitor policy, now is a good time to start looking at that. Know what it says. CDC really recommends that you restrict non-essential visitors whenever possible. Now, in the event you have to allow visitors in, like the story we had earlier about it being the holidays and some other things, try to screen those visitors to make sure that they themselves are not ill. Now, this is a pretty acute onset, so if I have a feeling if they're sick, you're going to know because they feel so terrible. But they may have been exposed, like if one of their children came home from school earlier in the afternoon with it. Might be a good time to screen people. And when the visitors come in, please train them or educate them about how important it is to perform hand hygiene with soap and water and to really watch what they're touching and not spread it around, and to be on the lookout for symptoms. Now, very quickly, I'm just going to talk a little bit about cleaning. We do recommend that you move to bleach during an outbreak setting. Remember that cleaning and disinfecting is actually two steps. So if you have a surface that's contaminated with vomit or stool, you need to clean that debris first, physically remove it, and then disinfect the surface with a bleach or an EPA-registered disinfectant. It's important that your housekeeping staff know to do this. Also, really watch how you clean the room. You want to move from areas of less contamination to more contamination and not the other way around. Sometimes what we see is housekeepers will wipe the handle on the flusher and then go wipe the handles on the sink. And that is a great way to pick up norovirus and put it right where you're trying to wash your hands. So make sure people know to do a high to low, clean to dirty cleaning method. It really does help. Change your mop heads really often. Again, if you have supplies this particularly for hospitals, if you keep supplies in the room, take them all out when that patient gets discharged. You want to rewash any linens that have been stored in the room because they could be contaminated. Laundry services you want to make sure that you're not shaking out the sheets or the towels, and I'm doing this motion with my hands. Amy's laughing at me because you can't see it, but remember, this can be aerosolized. So when you're working with linens, you probably want to be in full garb, gown, gloves, mask, just as precautions. You don't necessarily need to change any of your practices. No double bagging. You don't have to red bag anything. Just normal, but just make sure you don't create turbulence. You do not need to move to disposable dishware. As long as your hot water and your dishwashers are working well, it should be fine. Upholstery, steam clean it, particularly if it gets vomit on it or other nasties. And really, if you can avoid upholstery altogether, that's your best bet. But I know, especially in long-term care, that's very challenging. Privacy curtains, make sure they come down and get washed very frequently, especially if you notice any soil. But particularly as soon as the resident or the patient is starting to feel better, go ahead and get those privacy curtains changed out. You want to consider whether or not you need to close your ward. This needs to be an executive decision. You can also ask your public health for advice on when to do this and how you would do it, but now is a good time to be thinking about what that impact might look like. If you're a hospital setting, you can discharge your patient with norovirus because, again, this is not a serious illness. If this is the only thing keeping them in the hospital, it might be in your best interest to go ahead and discharge them to home with instructions on how to care for themselves and when to return. Food handling, if you have any community food, you just had a party with finger foods, stop that practice right now. Throw that out. You want to make sure that anytime you're handling any food, make sure everybody washes their hands with soap and water prior to touching. Remember, this is a fecal-oral route. Norovirus is not inherent to food. It's usually, you'll see it sometimes called a foodborne illness, but really it comes from infected food handlers. So it's the person handling it that had the illness but then transferred it to the food, and not that it's just inherent in the food itself. And then last, I'm going to talk about hand hygiene because this is kind of controversial, and that is we say don't use alcohol-based hand sanitizer. Right now, we really don't have a good product that kills norovirus. There is some evidence that an ethanol-based hand sanitizer is more effective than isopropyl, but only just. And even the soap and water doesn't necessarily kill it. What it does is it just washes it down the drain and gets it off of your hands. So again, during an outbreak, train your staff that it's okay to use the alcohol, but soap and water first, and then apply the alcohol. That'll cover your bases across the board. So that's my presentation. I know it's really quick. I'm happy to answer any questions, but my take-home message is prepare for it now. Train your staff to look for it and drill, assess, make sure you're prepared because it is here, and hopefully it will not be in your facilities.
Thanks, Jamie. That was excellent. Before I turn it over to Jean Dupanier, there's a request from a participant that whether anyone has any templates or completed visitor policies that they'd like to share about how to handle visitors during a norovirus outbreak. So if any of you have any information on that, you're welcome to share information with each other. Again, thank you for asking questions. You're still welcome to ask questions during this presentation, but please be sure that when you send the question that you select all participants. If you send it to all attendees, then the speakers don't get to see what it is that you're asking, so that would be great. I'm going to, let me first turn this over to Jean Trepanier, and she's going to share her hospital's experience with a noro outbreak. So, Jean, are you there?
Hello, you can hear me okay?
Yes, ma'am.
Okay, sweet. Okay, so a little background. We're a critical access hospital that in the same building we have a long-term care unit, assisted living, a clinic, an ER, an outpatient physical therapy, laboratory, and radiology. So just as a little background. We had, since I've been doing this job, we've had 3 outbreaks, so I kind of have a love-hate relationship with the norovirus. I love its virulence, but I don't like it when it's going on. So back in 2012, I was notified that a resident on our assisted living unit was having GI symptoms, and staff did the right thing. They isolated the resident to a room per protocol, and so it's like, great. Well, the next day I came in, and there were 4 other residents and 2 staff that had symptoms. So I told staff we needed to get some stool samples, contacted the health department, and we did Noro protocol, which did include the 48 hours after last symptom isolation. We then closed the units, but we didn't at that time try to slow inter-trafficking like staff. We did have housekeeping beef up the bleach cleaning, and we did educate staff about soap and water versus sanitizer. On 3:30, one of our activity people reported some symptoms. When I came back to work on Monday 4/2, I had 2 residents on our long-term care unit that had symptoms and 4 staff. So that was a big bummer, and I think part of that not halting inter-trafficking was part of that. So we had staff stay home for 48 hours. I had the staff get samples, and it did come back positive for Noro. So we sent out an email to staff indicating the presence of Noro. I had sent out others before that, saying we had a GI bug. Put signs on entrances. We blocked off all the units. Admissions to long-term care and assisted living were held. And so then we had a couple more days of symptoms, and it was about the 3rd of April, I believe, that staff noted that the residents, the cognitively challenged ones on assisted living, they weren't staying there, despite the fact that we had a sign on the door saying that we had I believe it said something like a nasty GI bug going on or something. I don't remember exactly. So we changed it at that time to, there's a nasty bug in the building. Please check with the nurse before going out. And quite honestly, that beefed up the effectiveness of them staying there over 95% of the time. And I think part of it was like, okay, they said, I don't have a GI bug, so I can go out. And instead we phrased it to say, hey, there's a nasty bug, go talk to the nurse. Then by the time they got there, they were distracted, I believe. The next thing we did, I wish we would have done these things sooner, decided that residents who are independent in eating would go ahead and stay in their room, which included those from acute care, and that didn't go over so well because they enjoyed their socializing time. And then on 4 or 5, we kind of talked about the holiday thing. We decided to go ahead and telephone families to talk about the risk versus benefits of visiting or taking their loved one even home for the holiday. So finally that end, after 10 days of start to finish of reports of illness. And I think, we isolated. That was great. We should have halted activity sooner and halted the interdepartment trafficking sooner. We did not. We found out that we didn't have enough isolation carts on assisted living. That was a major bummer, but we improvised with just using a main area one. So great, good, it's done. Okay. So then in October, I come to work on a Monday, and a dietary person says, hey, do you know there are 8 residents in their room on AL and 3 staff ill? So there we go again. We closed AL immediately. We halted the SAIL class, which I didn't mention before, which is kind of a helping patients to prevent falls. Then we had a lot of community members come in for that. We put the signs up again. We closed the units quicker. I found out like 7 days after the first initial presentation that one of the residents from assisted living had gone to the clinic with the complaints of diarrhea but had not communicated this to nursing. And because they make their own appointments sometimes, so provider did not communicate with us. And then I found out staff that there was an attitude of, these residents are independent, they don't have to tell us. So I had to encourage staff to be more proactive. One thing I did, you mentioned toothbrushes, which I appreciated because we did do that, which I think might have helped prevent that spread a lot. And then another challenge we have in assisted living was they have carpets over there in all the rooms, and being assisted living, they don't have staff sinks in the rooms. So that was quite a challenge for us. So then in January of 13, So the first two, we kept it from our acute care, but we still had it, which is a bummer. In January of 2013, we had one day I get notified of 3 acute care residents having symptoms. Next day, another one. We again got stool samples immediately. And then I found out that some staff members had been having symptoms like the 15th, the 19th, and that they didn't notify me, so I didn't know. So we went through this outbreak. I had to do a lot of teaching to staff to what everybody's talked about, especially Jamie, about notifying even on the day off. That's a hard thing to get people to do. And this one lasted longer, which was weird, and I couldn't figure out what was going wrong. And mind you, it was rampant in the community. It was noted midway through that, and I don't know if anybody else has thought of this, but I noticed that staff weren't wearing the booty protectors, and so I ensured that those were on the carts. I can't tell you if it helped or not, but it was just one thing that I did notice. And the big thing there is it didn't go to AL that time. So I think that's all I have to say. So thanks.
Jean, thanks so much for sharing your stories. That was great. Thanks so much. And then we're going to hear from one more person. We're going to turn this over to. Okay, why is this not? Okay. We're going to turn this over to Dave Brantley, and then we have a few questions before we wrap things up. So, Dave, go ahead and take it away.
Thank you so much. I'm the Director of Nursing of a large skilled nursing facility in Vancouver, Washington. I want to really heighten as I speak about the time frame and what reacting dramatically can do to shorten the duration of an outbreak. So we first noted 3 patients with symptoms on January the 3rd of 2013, and we placed them on isolation. One of the first things we do is we stop using any items that will return to the kitchen. We use disposable plateware trays, utensils, and everything so that nothing's coming back out of those rooms. As a background, we had reported cases in our community the week prior, which is why we reacted so dramatically. We obtained specimens from those folks because we wanted to confirm what we had and started bleach cleaning of really high contact surfaces. We suspended admissions, which is not a popular thing to do in our industry. But in the end, we shortened this, and you have to help your senior leadership in a company see that this is a smart move because it makes them kind of a little anxious. We also closed the break room for staff, and we took empty rooms on each one of our wings and took an empty patient room and set up a break area so that we could try to do our best to stop any staff cross-contamination because we couldn't isolate this to one area. We went ahead and quickly ordered additional nursing supplies of everything that we might need and started enhanced education to the staff for how this works because there's a lot of misinformation out there. On the second day, we had an additional 5 patients reported with symptoms, and we continued that in-servicing because you got some different staff there than you had the day before. We suspended dining room meal service for the entire facility and began in-room tray service, and we used all hands, every employee in the building, regardless of department, to do our tray passes, and we designated people as dirty or contaminated. These folks took trays from clean folks, headed into rooms where we knew we had active people. So this really allows you to avoid any inadvertent spread from going from room to room. We suspended use of our therapy gym and started all in-room therapy. And then activities went out and purchased single-use activity items. We were put into use the disposable vital signs equipment. And we notified not only did we notify the public health folks, but we also notified the DC planners and the infection control folks over at our feeder hospitals, and we notified DSHS. We wanted to just be as transparent as we could be. The public health folks provided us some great staff in-service items that we went ahead and used. We cross-referenced our stuff with the Clark County Public Health control measures and integrated that. We posted kitchen personnel only in the kitchen so that nobody who was had, regardless of their department, went in to even get sweetener or anything like that. We kept the kitchen staff in the kitchen, and we really tried to keep people isolated into areas. This went into a weekend, so we gave a great script to our receptionists and folks to answer visitors' questions, and a letter that they could hand out to any family members. And we tried to get on the phone and notify every family member, the key family member of every patient, what we had going on so that we could slow things. So on the 5th, we went ahead and reviewed everybody that we had first noted on the 3rd and 4th, and had a meeting with Clark County Public Health to let them know where we were at. We upped the amount of cleaning of those high contact surfaces to make sure that we were doing a really good job of stopping this. The other thing that we did was we started making sure that we were getting sufficient fluids into the people that we knew had a problem, because that's where one of the primary dangers comes in contact. We got our first positive lab result on the 5th, confirming that we had what we thought we had in the building. On the 6th, we had 3 additional new cases. So with all this, we're still seeing some additional folks, which probably had been infected before we started getting really excited. We had 2 day shift nursing assistants call off and 1 swing shift nursing assistant. So we've now moved this into to the staff as well. We were real good in our education about telling staff, make a bleach solution for your garage, your laundry room, wherever you can do so, and strip off when you get home and spray down your shoes with that bleach solution, bag that laundry, treat your family as patients and make sure you're not contaminating them, because that also is another way to stop the spread. We went ahead and notified our local newspaper, and they put it in the paper that we had this going on, because we thought the more people who know, the better. At that point, we also went to disposable utensils and trays and everything for the whole building, not just people that we thought were contaminated. On the 7th, we went ahead and did a symptomatic patient-by-patient review and did additional reviews of Noro precautions with each floor. And by the 8th, we're talking only 5 days later, we removed 9 patients from the tracking and saw our symptoms reduce dramatically, and we didn't see anything additional. Other things that we added that were really, I thought, were helpful was we didn't allow drink carts to enter the kitchen to help reduce that traffic. We started wiping down everything inside the kitchen as though it had been contaminated. And we were just pretty much, if it didn't move, we were cleaning it up with bleach. So I think the key thing that I want to point out to everybody who's on the call is react dramatically, assume this is what you have, think about what you think is prudent, and go beyond it. You'll stop this faster, and you'll have your staff understanding just how dramatic this is. I have worked in places in my 35-year career that got kind of panicky and tried to downplay. I truly believe that's the worst possible thing you can do, because where it leaves you is allowing the spread of the infection to go on because you're trying not to make people too anxious. The disease will make people mighty anxious once it happens, and in a look back, you may feel like you put some people at risk because you didn't get carried away too quickly. And I believe that if this ever happens again, we'll have the full support of our corporate office for any kind of suspension of admissions and getting really carried away, because we were able to end this so quickly and there were no significantly negative outcomes for any patients. And I just believe the faster you get all precautions in place, the faster you'll end the outbreak and the safer everybody is.
Thanks, David. And those are some excellent points, that you shared with all of us, that, norovirus is going to happen, and so it doesn't make sense to try and shame it, but just to react very quickly and appropriately, that will help prevent the spread. So the excellent viewpoints that you were sharing. So thank you for that. And I'd like to thank all the presenters for that. I realize that we've gone a little bit farther than we had anticipated originally, but we would like to have an opportunity to have some discussion. And we're going to read a couple of the questions that have come through chat, but I want to remind you that for some people who could only join by audio, you won't be able to participate in the Q&A or chat, so you'd have to log in. And for those of you who are logged in, if you have a question, please be sure that you send it to all participants. If it's sent to all attendees, we may not be able to see it. So, I'm sorry, what?
We on the panel.
Yeah, we on the panel cannot see that. So, I'm going to read a couple of questions that have come in. So Linda Hilberg asked if the norovirus is still contagious when still on incubation period, not showing any signs or symptoms yet. We answered that, and the evidence is that it is contagious after symptom onset. So there's viral shedding in stool and vomit. There's a question about whether it's okay to use hand sanitizer to cleanse the hands instead of hand washing.
The recommendation is not to use hand sanitizer because it leaves the viral particles in place, and there is evidence that alcohol does not kill norovirus. Therefore, your best bet is to move to soap and water.
Thank you. All right. Amber Gray had mentioned that if for people who want to get some information for visitor notifications, in Idaho, their Department of Health includes signs for facilities including visitor notations, and so that may be a place where you can all start is looking for your health department. Also, Laura Showers very kindly offered that if she has a copy of her visit policy, she'd be happy to share with anyone who's interested. So contact us and let us know, and we'll connect you. And so we'd like to know if there's any additional questions at this point that you may have.
If you have a question, use the raise hand function so we can see you and open your line.
Okay, I guess not, and I again recognize that we're at the top of the hour. So some take-home points, we're just going to wrap it up very quickly. Again, expect norovirus. It is something that is highly contagious, and it's being in critical access hospitals and nursing homes and other areas that have a lot of people in confined space. It's more than likely that you will tackle it at some point, and so that's going to be expect that it may happen at some point. If not this season, it may happen next. Be proactive with the surveillance. Again, looking at who may have had may not be feeling well, not just with your residents but also your staff, and having your staff educated as far as if residents are having symptoms that they need to take that seriously and report that, and so that further precautions and monitoring and some testing can be put into place. You want to test your systems before an outbreak occurs, so making sure that your staff have the training into what to look for and knowing what to do when they see a resident who has symptoms with norovirus, and also that how they monitor their own exposure, that whether staff are having symptoms of norovirus or they have a family member or close friend who they've been exposed to, and what to do. You want to do that before the outbreak occurred. So again, be proactive and not reactive. That also goes for making sure that you have adequate supplies. You want to make sure that when it comes to norovirus season, you want to make sure that you've got some masks and gowns and other supplies on hand before a potential outbreak, because scrambling during an outbreak is just going to add one more stress to you. Act quickly to contain spread, and you heard this emphasized by some of the presenters today. And also, we want to emphasize, don't be shy. Reach out to your public health partners at the Department of Health, who'd be happy to provide some other guidance and help if you need that with a norovirus outbreak. And so we just got another question. Does Interact have a norovirus pathway available yet for nursing facilities? I'm not aware that it does with the current version of Interact 4, and I don't know if there are plans for that. But tell you what, Nicole, we'll take a look at that, and if by any chance they do have one, I can send that. Jamie, do you have a comment?
I don't have a comment about that, but I know I got a question earlier about whether or not there is immunity to norovirus, and I wanted to just address that really quickly. There is evidence that once you get sick, you do have a limited amount of time for immunity to that specific strain that you were ill with. Right now, it looks like CDC says maybe up to 24 months. Maybe not. So one of the strategies you can use if you do have an extended outbreak is if you have a staff member who's come back from a recent illness, that person should have some immunity, and you might want to assign that person to your ill contacts and ill patients and residents. Do know that this can evolve every 3 to 4 years, and so whatever immunity you may have previously had, you probably will not have with the new strain going around. So I just wanted to address that.
Thanks, Jamie. All right. So we've gone over our time. Thank you all so much for coming today. We'd like to especially thank Laura Showers, Lori Bensler, Dave Brantley, Jane Trepanier, I'm pronouncing it the French way, sorry, Jamie Moran, and also all of you, critical access hospitals, long-term care facilities, corporate folk. Again, we really appreciate the turnout and the interest. So thank you for coming today. We'd like to ask if you'd be so kind to let us know how you felt this webinar went for you. So please take a few minutes and fill out a SurveyMonkey. The link is provided for you at the end of the presentation, and we do take your feedback seriously, so please let us know if you found this to be valuable, and if there was something that you felt would have been more valuable to you, please let us know for the future. And if you have any further questions, you're welcome to contact Tracy, Treasurer in Idaho, or myself, Amy Ford, here in Washington State. Thank you all so very much.